Hey, this is Andy.
And Randy.
And we're here on AT Corner.
Being an athletic trainer comes with ups and downs, and we're here to showcase it all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. For this education episode this week, we are going to the Chompers. We are going to be talking about the position statement on dental emergencies.
And this is a CEU thanks to Mass General Brigham, formerly known as Precision AT. So make sure you check the show notes for how to get your CEUs. Have you ever had a tooth injury that you've had to deal with? I
actually have. I've had one in my career so far. Knock on wood.
What sport?
Come on. You know, track and field, baby. The sport you would not think of necessarily having a tooth injury is how I got it. And
I assume pole vault.
No. It was actually one of our sprinters. It was a weight room injury. I think, I can't remember what he was exactly doing, but he hit the bar and it basically took a chip out of his tooth.
What'd you do?
We referred him to our team dentist. I think he was seen that day, actually. We couldn't, from what I remember, I can't remember if he had the piece that chipped off or if we lost it.
For a chip, what do they usually do? Like, do they usually use the chip or do they usually...
See, that's the best part about our session in Houston is they talked about that. And if there are pieces that you can gather them. Because they were saying sometimes you can actually use the actual natural part of the tooth and use that to help heal it.
I guess, like, as a general blanket statement, you probably should anyway, even if they can't use it. Because you might as well...
Yeah, might as well.
Yeah.
But yeah,
might as well try.
They did say, like, any fragments they technically can try and use as they're gluing everything back together. If not, it's not. They were saying it's not the end of the world. So I think in this case, I don't think the kid had it, but essentially they just kind of like recreate that part of the chip.
Yeah. So for those of you who do not know, we just came back from Houston, Texas.
Yes.
With Sports Medicine Broadcast. He invited us to go co-host some interviews, and we interviewed two dentists, married dentists, which was really exciting.
It was, yeah.
And they gave us a great talk on sport-related dentist industry.
Injuries to dentists.
Yes. You don't see those all the time. Dental injuries, which we should have on the podcast upcoming sometime in the next season. But for now, let's head back to this position statement.
Yes.
So, as we like to always start... Well, actually, did we talk about what we're even talking about in this episode? You want to go over the objective?
Yeah, we should probably start what our goal is to begin with.
Let's start with that. And then we get to get in the nitty-gritty.
So kind of like what we kind of alluded to at the start, you know, we are going to be diving into the position statement on managing and preventing sports-related dental and oral injuries. And it was a really cool position statement to read. I thought there were a lot of good stuff that I feel like aren't touched on a lot when you're a student. So it was really kind of cool. Like, I never really thought of this, or yeah, good point kind of thing. As with most things, we're going to talk about some anatomy. So we're going to talk about the anatomy of the mouth and the tooth itself. And then we'll just kind of briefly talk about discussing building a relationship with the team dentist and what kind of role that team dentist plays within your sports medicine team. That's a good buzzword right there. Sports medicine team.
Yes. You know, I was one of my favorite parts about teaching the lecture on sports medicine team is talking about the team dentist, because I feel like no one thinks about having a team dentist
until you need one.
Right.
And then you're like, we need a team dentist.
No.
What do I do with this?
Who do I call?
This tooth is not where it's supposed to be. What do I do with it now?
So, as we like to always start out with...
Anatomy.
The anatomy.
Yeah, so the anatomy of the mouth and tooth, right? Really basic, right? You have 32 teeth, right? 16 are on the maxillary arch, right? So the roof of your mouth, and then 16 on the mandibular arch, or the bottom of your mouth. There are, within each of those arches, there's 2 central incisors, 2 lateral incisors, 2 cuspids, 4 bicuspids. These are your premolars. And then you have 6 molars. So
we were talking to the dentist about these, and they were saying, basically, you don't have to worry necessarily about the anatomy, but do take pictures. They really appreciate when you take pictures, because then you don't have to say, I think it's a cuspid or a bicuspid, or it's the dentin, or, you don't have to figure that out. Just send pictures and they can figure it out for you.
They'll go from there.
Right.
And it is nice because, I mean, it seems weird, but like, the mouth and teeth itself have their own set of anatomy to talk about, and directional anatomy, which we'll kind of talk about a little bit. But it's true, like it's a complex system, hence why they have their own specialty.
Right.
So it is a complex kind of situation that we are kind of just expected, hey, know the bare minimum, the basics, and then
this is a tooth.
Yeah, exactly.
It goes in your mouth.
So speaking of this is a tooth, all right, the anatomy of the tooth itself, right, is divided into two sections, right? You have the crown and then you have the root. So the crown has the enamel. So this is going to be your outer layer. This is what I thought was interesting because you really don't talk about enamel. You're just like, enamel protects the outside of the tooth. Here you go. But it's kind of cool because how the enamel is arranged is it's kind of the substance of enamel is actually kind of arranged in prisms. And the reason that's interesting is because it kind of plays into how some pathologies present, because it's laid out in prisms as opposed to like, oh, just flat or like, straight lines. So I thought that was kind of cool to kind of think of, it's not just like a sheet of material. There is actual some kind of arrangement to enamel. So I thought that was kind of cool.
Like 3D?
Yeah. Like if you're kind of thinking of it in a 3D space, it'd be like more prism-like as opposed to like just straight lines or something, or like a sheet of something. Under the enamel, you have your dentin. And this is the kind of the porous aspect of teeth. It's dentin has like little tubules, and this basically allows for that communication with the pulp, some of the outside layers. So this is how things are getting transmitted. All right. And then underneath the dentin is your pulp. This is basically the whole functional unit of your teeth. All right. So the pulp contains the nerves, vascular supply, lymphatic supply, all the fun stuff. So essentially, and basically, all the stuff that really makes you hate teeth pain and going to the dentist.
Right, so this is like the nucleus.
This is the nucleus
of the tooth.
Yes. So the functions of the pulp, I thought the position statement did a really cool job of explaining exactly what does the pulp do. So the position statement basically laid it out to 4 functions of the pulp. Right? It's formative. So essentially it creates things. It creates structures, right? And this is, in this area, houses the odontoblasts.
Does that build odontin?
It does build odontin. Yes, it builds the dentin for sure.
Dentin.
Yep. All right.
Okay, that makes sense.
So it's kind of like the same idea as a osteoblast kind of deal, right? Building bone, right? Well, this is specifically for building dentin.
See, that's what I'm talking about, because it's blast.
Yep, exactly.
Osteoblast.
Fibroblasts.
Fibroblasts. Odontin blasts produce dentin.
Exactly. It also serves as a nutrition role, right? Because of that blood flow, right? Mm-hmm. That access, right? It's supplying nutrients. And obviously, what most people associate the pulp for, the sensory component. This is what gives you the ouch.
Of tooth pain.
Tooth pain, yep. And why a root canal used to suck. It probably still kind of sucks, but not as much nowadays. Used to be a lot more painful, I hear. So big sensory component, right? Mm-hmm. And then I thought was interesting, it's kind of obvious, but also the defense role, right? If it's a mild irritation to your tooth, right, the pulpit has the capabilities of repairing the dentin, right? Hence those odontoblasts. But it can also help signal that inflammatory process, right? So when you're thinking of inflammation, around the tooth, stuff like that, it's coming from this kind of idea. Right? This is how you're getting that process. And as with most inflammatory processes, if this goes on too long or is too severe, it can actually lead to damage to the tooth, eventually leading to this tooth is going to die and it's got to go.
So pulp really is the big boss of the whole tooth system.
The pulp is where things are happening. All the other stuff of the teeth are just what make them look good.
Okay, so what about like a root?
Yeah, so the root part, right? So now the crown is what we see. Right, the root is what we don't see. The root has the same layers, except for it doesn't have the enamel part, right? So it has dentin and it has pulp. But kind of like the crown having enamel, the root contains what's called cementum. Right, so this is kind of the enamel of the root. Right, it's that outside layer. Right, and basically what the cementum kind of helps with is it's basically a site of connection for the root. So the cementum connects with that socket via the periodontal ligament, or the PDL, as what the position statement kind of abbreviated it as.
So this periodontal ligament, I've heard, is flexible when you have braces?
Yes, that's what's kind of helping allow change how your teeth align, because this ligament is essentially what's helping hold your tooth in its socket.
Mm-hmm.
Right. So yeah, like you said, like right when you have braces, it's stretching it and making it more lax, and now boom, now you have straight teeth.
Is that all we got for anatomy?
That's anatomy. No, that is not anatomy. Now we have to talk about the orientation, right? So when we talk about most like anatomy, right, you talk about your cardinal planes, right? What's sagittal, frontal. Well, the mouth kind of has its own kind of set of directions. All right, so if you ever hear someone talking about buccal side, right, that's the side closest to the cheek. If someone says lingual side, that's the side closest to the tongue. Labial surface is closest to the lips, so this is kind of like the front of your
like
of your
anterior.
Mouth. Yep, the anterior.
Buccal, lateral, lingual, medial.
Yeah, kind of. Yeah, exactly. And then the occlusal surface, this is the actual area where like the teeth meet. This is the biting surface, basically.
Where they occlude.
Yep, exactly. Now you can say that's it on anatomy.
Woo. Okay.
At least for us. For the dentists out there, it probably gets a lot more intense.
It's all we need to know.
It was also really cool, a little off topic, but going through the position statement, they actually showed the numbers of how they number the teeth.
Oh, you know what?
And
Every time they do that at the dentist, I wonder what they are doing.
I thought it was really cool. So it actually shows the arrangement of what tooth is number 1, what tooth's number 2. So it was really kind of cool.
Like in baseball, what position
exactly. Yes, that's
what?
an error on incisor 1. All right. So now to the nitty gritty. What most people are really trying to dive into this position statement, and that's actually talking about, okay, we have dental problems. What do I do with them? And it could really kind of be boiled down to fractures and then eventually the avulsions, right? So we'll start with the fracture portion. All right, so they divide it up into either a crown fracture or a root fracture, right? So for your crown fractures...
Oh, that's why we have anatomy.
That's why we had the anatomy portion,
it's like
right?
the tip of the iceberg. Like the crown is the part you see and the root's the part you don't see.
Yes.
It's like icebergs.
Exactly. So before we dive into fully to the crown fractures, you have what's called a crown infraction, right? And essentially this is just disruption of the enamel, right? It's defined as disruption of the enamel prism. And the reason why I thought it was important to note that enamel's arranged in like a prism-like material is because when you look at it under light, you'll see small cracks in the enamel, and this kind of gives away a crown infraction.
Any light?
Yeah, I think if you have like a little flashlight deal, you can see the small little cracks in the enamel.
Okay.
For a crown infraction, this is a non-emergency. It should be referred, but you can return the athlete to play as long as they have a mouth guard.
Okay, so cracks in the enamel.
Yep.
They can still play.
Yep.
With a mouth guard.
Yep.
Got it.
Anything that returns to play in this position statement, you will see needs a mouth guard.
I mean, makes sense.
Yes, makes sense. Right? You're trying to prevent further damage.
Right.
That's
all right. Basically like our knee brace, our ace wrap, our arm sling. It's something but it's for the tooth.
Exactly. So now going into the actual full-on fractures, right? We were just talking about cracks. No, this bad boy, we're going into layers.
Yeah, apparently cracks are not the same thing on bones, right?
Exactly.
A break is not the same thing as a fracture suddenly.
And it's really kind of easy how they define these fractures, right? They basically define what kind of layers are going into. So an enamel-only fracture is really kind of going through multiple layers of that enamel. So it's actually going into the enamel as opposed to just kind of damaging it, if that makes sense.
But it doesn't necessarily have to be broken off.
Yes, exactly.
Okay. So we can get a full break. So some cracks would be a infraction.
Yes.
But a full enamel
it's going
crack.
It's like going deeper into the enamel.
Okay.
So
that would be a crown fracture.
Yes.
Okay.
An enamel only crown fracture.
Got it.
So for the enamel only ones, this what I thought was very helpful is they'll present with roughness along the edge of the tooth, right? So if you were to have your patient like kind of rub that tooth, they would feel like, oh yeah, it's really rough right there. That can be an indicator of an enamel only fracture. And to be honest, they were saying that most people kind of don't know they have them because there's no pain with it. Right?
But can you see it?
You can see it. Yeah, you would be able to see it, and they would obviously be able to feel it. Like, oh, this one's a little rough. Right? It's a little bit different than the rest of my teeth. All right, so key with these ones, because it's just the enamel, there's really not pain or any temperature sensitivity associated with it. All right, so kind of similar, right, as to like our other enamel damage. This has to be referred, but it can be delayed. All right, but they may return to sport with
a mouth guard.
All right. Now, as the fracture goes in deeper, right now we're talking about an enamel dentin fracture. All right, and this fracture, when you're looking at it, you'll see that thin white enamel, but then underneath, you'll actually see the yellow layer. That's the dentin. All right, the dentin is a little bit yellowish, so you'll be able to see both layers. Because it extended further into the tooth, now you're talking about pain, and they will have some sensitivity to temperature.
Okay.
Right, and this is air too, so if they're breathing, right? Ooh, yeah, I just breathed, it hurt a lot. Or like, ooh, I just drank water. Ow, this really hurts. Right? That's what we're talking about, that sensitivity to temperature. Now, the cool thing with a lot of these, some or most of these dental injuries, they have a lot of conditions where you return to play, as long as pain permits it.
Okay.
Right? So this is a situation where they can return to play with a mouth guard as long as their pain permits it. I don't know. Maybe I'm just a baby, but if my mouth hurts, I'm like, I don't feel like playing basketball right now.
Adrenaline, baby.
Yeah, that's true. Right? But if you do have an enamel dentin fracture, they must be referred to a dentist within 24 hours. So they can finish the game.
But call your bud.
Yeah, but they're going to have to be seen pretty quickly.
Right.
And then finally, right, as we're going deeper with these fractures, you can get an enamel dentin pulp fracture.
3 in 1.
That's right. You're going all the way through the tooth.
Okay.
Boom. If the tooth is pretty healthy, you'll see a focal spot within the tooth that has some bleeding, right? Because obviously that pulp's pretty active, right? That's where the blood flow is. So you'll see a little focal hemorrhaging in that part of the tooth. If it's a tooth that's not necessarily healthy, right? If that tooth's on its way to death somehow, you won't see any bleeding, but you may smell a foul odor from the tooth, because obviously inside the tooth's dying. They may not complain of pain because, again, the nerves and stuff in that tooth they're not really working.
Mm-hmm.
And then they may just have some seepage of like some fluid coming out, or even a hollow space within that tooth, right? So keep that in mind, right? If you're looking at someone who's healthy, you're probably going to see blood. But if it maybe is someone who's had a long history of teeth problems and they're having decaying teeth, you might not see much in that spot. Again, even a fracture going all the way through your tooth can return to play as long as their pain permits with a mouth guard.
Now, this is, again, talking only about the crown fractures.
Yes.
So we are so far only covering what you can see.
Yes.
So if it's something above the root that you can see, it is something you can return to play with a mouth guard, even if they're in pain.
Yes. And again, an enamel dentin pulp also must be referred within 24 hours, right? So it's going to be pretty quick.
So, I mean, essentially you're calling your dentist anyway.
Yes.
For any of these.
Yes.
But most likely the more severe it is, the more likely they're going to have to see quicker.
Yeah.
Another thing that I'm thinking of is, I mean, it is going to be in your management plan anyway.
Yes.
But if someone is in so much pain that they are paying more attention to their tooth than they are the game, they could be at more risk for further injury for something musculoskeletal.
Yeah, exactly.
So right. I mean, that's just going to have to be in your management plan anyway.
Yeah, absolutely. That's definitely going to influence your decision making as well.
Right.
All right. So that's what we talked about, right? We're talking about The Crown, right? Not the Netflix Crown, The Crown, even though that's a great series, right? Just the tooth. But now we're diving under these gums. We're going to what you can't see. All right, so they also categorize root fractures. And there's 3 different types of root fractures that we're going to talk about. And this basically depends on where they are in the root. So it's categorized either as an apical 1/3, which this is the deepest, right? This is the closest to where the bottom of the root is.
I feel like that's so misleading because I think apex, like the top, but I guess apex, like the deepest,
is more like a point, and that's the most point of the tooth.
Okay.
Right, and then you have the middle 1/3, and then the cervical 1/3, again, which is kind of weird because you're thinking cervical close to the head. Mm-hmm. Cervical is closest to the crown.
Okay.
Yeah.
Okay.
See, mouth anatomy's wild.
Yeah.
All right.
Well, technically, you can also say the cervical one is most lingual, closest to the tongue.
Yeah, you would be able to say that. That's pretty good. Look at that.
Hey, I'm just using my anatomy.
So the apical 1/3 fracture, right? This is deep in the socket. This is as deep as you can, and sometimes it's really difficult to detect because there's not a lot of instability with this fracture because, again, it's the deepest portion of it. So most of that tooth, most of that root is still anchored to something. Mm-hmm. All right, so this could be very difficult to detect. So the management of something like this, right? Referral can be delayed because the tooth's going to be pretty stable, so you're not too worried about it moving too much. So as long as they have a mouth guard, they can return to play.
So if you can't see it, you're just mostly based off of pain?
It'd be pain. And then as we talk about these other fractures, there'll be some instability associated.
Okay. So this is kind of something you're like, man, I got hit in the jaw, hit in the tooth.
Yeah, this hurts.
It hurts. You look, you do your inspection, you can't see anything.
Yeah.
You send it, or you say, okay, well, I'm going to make sure you have a mouth guard. I'm going to send you back to play. I'm going to call our team dentist.
Yeah.
And then,
Get some thoughts.
Right. That's when they take the x-ray and they're like, oh, you actually have an apical fracture.
Yep. So the middle 1/3, right now, this is the middle of the root. With this one, you can actually see what's termed as like an elongation of the root. So basically the root, because the tooth, elongation of the tooth, because there's a fracture to the root, basically the tooth's dropping out a little bit. So it's going to drop down more than like your other teeth.
Ow.
Right? Because it's separated a little bit. All right. So the management in this case is you're going to reduce it essentially, right? With finger pressure, right? Kind of.
Oh, you mean the top is going to, like if it's on the top of their mouth?
Yeah.
It's going to drop
But
down?
also too on the bottom, like it might be higher.
Okay. I was thinking a bottom tooth. So when you said drop down, I was like.
Yeah. No. So So that's why they do have that term elongated, right? It's going to look more out compared to the other.
Okay.
So reduction is going to be with finger pressure, right? So you're just going to push it back in. If it's pretty stable, right? It's not really loose. Again, the athlete can return to play with a mouth guard.
Well-fitting mouth guard.
That's right. If it's really unstable, nope, that's it. You're done. Immediate referral to a dentist because obviously something's really going on that it's not staying. And also that could be a danger. Right? Tooth comes out.
Mm-hmm. They swallow it.
All bad.
Okay.
And then we will talk about teeth coming out. So there you go. And then finally, you have the cervical 1/3 of that root being fractured. And this is, again, the closest area to the crown. And essentially, the whole crown part is going to be hanging basically to the gums.
Ugh.
The gums are going to be basically holding this bad boy together. And obviously, there's going to be varying degrees, right? Immediately when I think of it, it's like, oh, it's just hanging there. But, right, like, it could be, like, somewhat fractured, but still pretty stable in there. And that's exactly how you're going to manage it. All right. To stabilize, you want them to bite down on gauze, right? Because that's going to stabilize it.
So wait, why is... Sorry, keep going.
Oh, well, no, I was going to say, if it's relatively stable overall, they could still return to play with a mouth guard. So them biting on the mouth guard will stabilize it while playing. Like, right? Like if it's not like significantly loose. But again, should be referred within 24 hours still. If it's, again, unstable, right? Like if it's really just holding on just by a little bit, that's an immediate referral. Like you got to go. And then again, you bite down on gauze to stabilize.
Okay.
So when it's referral time, we're biting on the gauze.
Keep it in place.
Yep, stabilize it.
So if a root fracture that you can't see is unstable, then you are sending immediately.
Yep.
If it is stable, you can mouthguard, return to play, see a dentist within 24 hours.
Yep.
Okay.
There you go.
Just packaging up nice.
Exactly. Now we're going to talk about the actual, this tooth is not where it's supposed to be. Right? Tooth's not fractured. Right. The tooth looks pretty good, but now we're talking about it's not in its normal spot.
Thank you, basketball.
Yes. All right, so they have what's called obviously a subluxation, right? Which is similar to what like a subluxation in a joint would normally be, right? And then they have what's called a tooth concussion. A tooth concussion is basically just a fancy way of saying a bruised tooth.
Does the color come back?
So that was the interesting thing with talking about our Houston session. A tooth concussion is actually kind of significant because sometimes that it's going to stay like a off color, and it can actually lead to death of the tooth.
We don't like that.
Yeah. So depending on the severity of it, it may stay like that, and they have to do something to that tooth. So that's why the management plan is essentially monitoring it. Hey, we're going to look at this thing.
We're going to see what it does.
Yeah. A subluxation essentially is minimal instability, right? It kind of shifted, but it's still pretty solid, right? A tooth concussion, subluxation, again, can return to play with a mouth guard, but you're going to want them referred within 24 hours.
Okay, so tooth that is discolored from bruising,
Yep.
or a tooth that is a little bit unstable, which you don't know if it's technically a subluxation or if it's a root
Exactly.
fracture. If it's a little bit unstable and you're able to stabilize it with a mouth guard, you can get them to return to play.
Absolutely.
Okay.
So
Also, what do you mean by minimal instability? Like
that's the up to clinical decision.
Okay.
Right? Like if it's barely moving, I would say that's pretty stable.
What about like it's moving but it's not going to come out?
If it's moving a lot, I think that's it. Because there's the risk that
of it coming out. But what if the mouth guard stabilizes it? Clinical decision.
Clinical decision.
Okay.
Go with your gut. Go what feels right.
As long as the tooth doesn't go in the gut.
Exactly. Yeah, you don't want the tooth in the gut. All right, now we're talking about teeth moving. All right, so these are your luxations.
Okay.
All right, so they have basically lateral luxations or an actual extrusion, which we'll talk about what an extrusion is as well. And this is essentially a tooth being forced out of its alignment, right? So a lateral luxation is basically it's shifting to one of the sides, whether it's buccal, lingual. It's just shifting somewhere.
Okay.
An extrusion is basically the tooth's coming out of the socket. But again, you don't know. Is it a root fracture or is the whole tooth just coming out?
Right.
So that's why I felt it was nice just say it's just not in its alignment.
Okay.
All right. Management is you're just going to try and realign it with finger pressure. So whatever way it is, you're going to try and put it back the way it should be somewhat normal. They're going to bite down with gauze to stabilize, and then that's an immediate referral.
So far, and I think in the future of this episode too, pretty much if something's out of place in the mouth, in the tooth region, you're going to want to try to put it back.
Yes.
And if there's something missing, you're going to want to find that missing part.
Yes, exactly. Exactly. All right. And again, if it moves, right, if it's moving a lot, that they're done.
Okay.
An intrusive tooth. So this is actually the tooth being forced into its socket. So it's basically going to look shorter than the other teeth.
Which is opposite of a
extrusion
or a root fracture to the
middle one.
Middle. Okay.
So again, an intrusive luxation, right? The tooth getting forced into the socket, that's immediate referral as well. Right? Because it's getting forced into a place it shouldn't.
And that one we're not trying to
we don't have to do anything. It's pretty much stabilized.
Right.
It's really forced in its socket. All right, the one that you really talk about with teeth being where they're not supposed to is the actual avulsion, also known as an exarticulation. This is the tooth coming out. It is out of its socket. It is not where it's supposed to be. All right, so the management is the kind of like what we talked about. Your goal now is we are trying to put this tooth back in its place. All right, so you should attempt to replant within 5 minutes.
And make sure that it's forward.
Yes, make sure that, right, if one side looks really smooth, that's the front. Right? If it looks a little like groovy, that's probably the posterior side.
But you have to be careful when you put it back in.
Yes. All right, so that's the one thing. Okay, the reason it's so important about how we replant a tooth is because we're trying to preserve the periodontal ligament, right? It's a very sensitive ligament, right? So if there's debris, you want to rinse it off with water. You can do milk, but no more than 10 seconds.
Saline.
Yep, saline, right? Saline will work. Right? Do not scrub it. Do not use chemicals because that's going to damage the ligament, and the ligament's what's going to help keep that tooth in its socket, right?
So it's got to be within 5 minutes.
Yep.
You can rinse it off, but don't scrub it.
And also, when you're handling it, only handle the crown end.
Don't touch the root.
Don't touch the root because that will damage the ligament.
Oh.
Yeah.
So it's almost like, I don't know why I'm thinking about this, but you know, like baby birds, like their little eggs.
Yeah.
Like you can't touch them.
Yeah.
When you find a nest, like don't disturb the nest.
Yeah.
Otherwise the mama bird's going to not
Get pissed off.
Right. So same thing with a tooth. You have to be really careful. Think of it like a baby bird's nest.
Or the mama tooth is going to get pissed off.
Right.
Exactly. All right. If you're able to put that tooth back in its socket and it's facing the right direction, all right, the athlete will bite down on gauze to help stabilize it. And then that's an immediate referral. All right, they got to go now.
So call your dentist.
Yep. They're going.
So this is why you need a team dentist, because otherwise all these immediate referral things, who are you going to call?
Yeah. I mean, the position statement did say immediate referral to, right, dental professional or an emergency facility. But as we've talked to, like again, at that presentation, you're kind of gambling what that emergency facility has available, right? Not all of them have a dentist ready to go, and a doctor's not rolling up on this.
Right. You know, I got to say, best option, though, you can call a dental office and see if they have someone to call.
Yeah, that's true. That is true. Right. Obviously, if worst case scenario, right, the ER is going to be a good place to go. Right. If that's your only option and you don't know where else to go, right, there's nothing wrong with that because it's an emergency facility.
They probably just don't have a dentist there, but
there might be some logistical problems. Right. But again, we understand, like, hey, if you're in like a
if
rural
you're working
place,
per diem and you don't know where.
Yeah. So don't beat yourself up. You're like, oh, I don't know who to send. Hey, it's still, some of these are emergency situations, right? So it's just as you develop your plan, right? Here are some of those fine-tuned things you want to work into.
Right.
Now, if you cannot put that tooth back, that it's not going back in, it ain't happening. All right, you're going to want to put the tooth in a storage product. All right, this could be like most people think of Save-A-Tooth. Mm-hmm. All right, so it has a special enzyme within it that helps protect the tooth.
We heard from our dentist, Doctors Heiner.
Yep.
They recommended talking to your dentist to see if they have an extra Save-A-Tooths.
I know, that was cool.
Because some of them have some Save-A-Tooths, and they don't really need them in the dental office.
Yeah.
Like, they're not going to be like, oh, we need to save this tooth, right? Like,
yeah, exactly.
So for the most part, they're not really using them. So talk to your team dentist, talk to your local dentist, see if they have any that they can offload onto.
Another one that the position statement brought up that I don't know if this is what's in Save-A-Tooth or if it's a knockoff of what's in Save-A-Tooth or what, but it's called Hank's Balanced Salt Solution. And it really recommended using that, and it looks cheaper than Save-A-Tooth.
Interesting.
Yeah, it looks like a special bottle of saline. Yeah, it was kind of cool, and I'm like, oh, this could be, because like Save-A-Tooth is kind of expensive. Like, this could be an alternative.
But you know it's free?
Your team dentist, if they have extras.
Oh, I was going to say spit.
I was going to say, so there were some alternatives, right? You could use saline, right? You can also use the person's saliva because the enzymes within your mouth, right, can have some protective effect.
The only thing that I wonder about that, you don't want to use that as like your main, because if they have enough teeth like hit, and like they're bloody and stuff, they're not going to want to be spitting into a cup.
Yeah, no. And again, you can use milk. I believe it's low-fat whole milk. I believe that's
very specific.
Yeah, I think that's the milk.
If you happen to have that in your milk,
exactly,
in your HR.
Exactly. So those are some of the alternatives. Essentially, you want a moist environment for the tooth, right?
Not water.
Yeah.
Right? Not water, and there's something else.
It'd be preferred saline, yeah.
Okay.
But definitely not dry. You don't want to do like a dry gauze or anything like that, right? That's going to kill that ligament, and it's going to start affecting the tooth.
I have a question. I don't know if you know the answer to this.
Let's see.
What about, like, let's say a parent spit? Like, can a parent, like, if the kid is like bleeding, what if a parent comes up and is like, oh, I can spit into this cup?
I would say technically no.
Because it's not their
theirs.
mouth environment. Yeah. Okay. I was just,
right. Another alternative that they brought up, speaking of the saliva thing, is you could anchor it into their mouth, like put it
Okay.
in between their teeth and their cheek.
Oh, okay.
That is a possibility. I think that'd be uncomfortable if it was
Right.
me, but I guess if it worse, like you said, you don't want they can't really spit in there. Like, okay, well, let's just
I
shove
feel
it
like
in
that
there.
would damage the root because if you're not supposed to like handle the root.
I think it's just because it's the saliva. It's all right. Again, it's an alternative. That's probably better.
Here's
than,
some things that you
yeah.
can do if you need to.
All right, so there you go. There's your teeth injuries right there.
Sweet.
Now we're going to talk about how to protect them.
Let's do it.
We're going to talk about some mouth guards, right? We always talk about how mouth guards are important to protecting teeth, and it seems obvious, right? But actually kind of understanding the mechanism how I thought was really interesting because, again, I feel like we don't talk about why a mouth guard is effective. You just know, put a mouth guard.
Right.
Wear a mouth guard. And, again, evidence for mouth guards for oral injuries, great. They do a great job at protecting the chompers. All right. And the reason that it has this protective effect is, one, it basically spreads forces away from the teeth, right? It seems kind of obvious, but the material there, when something hits it, instead of all that force going to your tooth, it's now going up the mouth guard, down the mouth guard, to the side of the mouth guard, right? It's basically sharing that force with the mouth guard and then to your teeth, as opposed to the teeth now doing that job. All right, and then obviously it is a layer that has some give to it. It's going to absorb some force. So as something hits it, it's going to basically act like a net and go like, I'm absorbing. Like that. So it helps kind of add the time that force is being applied to the mouth. Now, when we talk about mouth guards, a lot of people want to bring out, how does it affect concussion rates? Right? And most dentists you kind of talk to, the literature is very inconsistent on if there is a protective effect with mouth guards and concussion, right? There's studies that say no. There's studies that say, yeah, there might be a small one. Right? And it's going off of a couple theories of, one that I remember was the actual separation between basically the TMJ, right? That being separated allows some force being absorbed and stuff like that, right? But at the end of the day, right, you can't necessarily say, hey, wear this mouth guard because it's going to protect you from a concussion. But on the flip side, it won't cause a concussion.
Oh, that's good.
Yeah.
So I heard that over the span of this research, we were kind of thinking it was leading that way, and now we're kind of shifting towards it doesn't really.
Yeah. Well, we also have to remember concussion's a very complex thing. We don't even know necessarily how much force causes a concussion.
Right.
Right. So it's still a new thing that we're learning. Right. It's just you can't tell people, hey, here's a mouth guard. You're protected against concussion.
You're great. Good job.
Right. If it does, great. But most of it's, hey, let's protect the teeth.
You know what it also protects? According to the dentist that we talked to, Doctors Heiner, they said that... Oh, actually, was this from them or was it Dr. Salapas? One of them who we talked to
about talked to a lot of cool people.
Facial injuries. They said that the mouth guard... I think it was actually the dentist.
Okay.
So, because they actually showed... They put a mouth guard on a skull, and they showed that the mandible actually distracts just a tiny bit from... like what Randy was talking about in that TMJ. So that condyle of the mandible actually is just a little bit inferior and anterior. So then when you get an impact to the jaw, for example, you are less likely to fracture your mandibular condyle.
Oh, yes, that's right. And
which
that's
is right up in that TMJ.
And that's one of the most common areas of fracture.
Of jaw fracture,
yeah.
right.
Another aspect, too, is when you have the mouth guard, right, you're biting on it, right? Biting that force helps with neck strength too. So that's another idea, right? So again, it's really inconsistent. You probably, shouldn't really be saying this is going to protect you from concussion because the support is just not there yet. But again, it's not going to cause one.
And we like that.
And
we like
that. All right. Finally, one of probably the most important things that we're going to be talking about when we talk about this position statement
is this action item?
Kind of ish.
Okay.
It's the team dentist part, right? Why a dentist is important to have, and also that emergency planning aspect. So the biggest thing when trying to get a team dentist is reach out, right? A great place to start when you're looking for a team dentist, because again, you don't think about it until you need one. And a great place to start is the Academy of Sports Dentistry, right? They have a great online database to where you can look up your area, here are all the dentists that are trained by the Academy of Sports Dentistry, so they know how to handle athletic injuries. Everyone, I feel like most dentists that we've talked to have been almost overly willing to be a part of your sports medicine team. They want to help. And I think that's been really cool.
People don't think about them.
Yeah, exactly. The nice thing too about having a team dentist is they can help give you recommendations on other dental professionals as well, right? Oh,
guess what? They have a network.
They have a network, yeah, right? Oh, we need a, what is it? A oromaxillofacial
Specialist
surgeon, right? They have that person, right? You don't have to sit there trying to look for that person. So, right, they can help broaden that sports medicine team to a higher degree. One thing that I think does get forgotten about is your EAP for dental injuries, right? We have an EAP for everything else, right? For obviously
or at least a
emergencies.
policy.
Yeah.
Like
right?
you have your lightning protocol.
Yeah, right. Get a plan in place where, like who are we going to contact, right? Who's our team dentist? Who are we contacting? Okay, what if it's after hours, right? Because let's be honest, right? Athletics happens weird times of day where the dentist is not in his office, right? 9:00, our dentist is not in his office, all right? So being able to, okay, who do I call at this time? Or where do I send them at this time? Mm-hmm. All right, so make sure you have that plan and make sure it's rehearsed as well, just like our normal EAPs. And then finally, try to include your team dentist with things, right? Like we said, you're really not contacting your team dentist unless something's happening, which again, dental injuries are a small percentage of what we normally see. So it can be easy to be like, oh, kind of forget about my team dentist, right? Include them in things, right? Just like you do your team physicians, right? Send them gear. I'm sure they love gear too, right? So right. Like if you're
treat them like a human being.
Exactly.
Who likes to have a sense of belonging.
Exactly. Right. Because again, yeah, I mean, when's the next time you're going to talk to your team dentist after one injury? Right? It might be a while. All right. So try to include them on like, hey, like we're doing a sports medicine get together. We should invite our team dentist.
Now, if you are like, let's say you have hockey or something, you can have them as part of your physical
yes.
Day or your health screenings.
Yes.
I was a part of hockey pre-participation exams that they had a team dentist, and then they went through and did like their checks. The dentist who we were talking to said that they participate in athletic physicals and they can take about less than a minute inspection per patient. So, it's something that if you're interested in that, you can talk to your team dentist and figure out what, what works for you.
And also setting. Help with the, getting custom mouth guards.
Yes, we did talk about that too. And the position statement didn't really touch upon that, huh?
It did talk about the mouth guard process, but not obviously the position statement included a fitted mouth guard is the best, right? It's fitted to you. That's the best way to go. It did go into different materials and stock and stuff like that. At the end of the day, if you're comparing no mouth guard to mouth guard, a mouth guard is always going to be better.
Right. And then keep in mind that there are certain ones that sit over the braces pretty well versus some that don't. So
yeah.
And your dentist can make a custom mouth guard for your athlete.
Yep.
And that increases compliance because if it's made specifically for them, it's going to fit better and it's going to feel better.
I was going to say it's going to feel nice.
And they're probably likely to take more care of it than, their boil and bite.
Yeah, which sounds terrible, to be honest. I'm going to boil this and bite it. Yeah, that's dental injuries right there.
It is. How many? Well, did you just use the
position statement?
Sweet. So if you're interested in the position statement, it's on NATA's website.
Yes, and again, as you should read the position statements, but really this one was a really good read because I felt like it went more in depth than what I remember us going into in when we were students. And again, it's a good reminder of how important a dental emergency is and being able to have a plan. And again, if you're bored this summer, it gives you something to think about, I need to add this now.
Right. It's also a good thing to review because we've all read the position statements, but even this is good, things that I didn't remember from the last time that I looked at the position statement.
I was going to say, and again, dental injuries, it's not super common. So it is one of those things oh man, I need to touch up on this because the last dental injury I had was years ago.
And you know what? To give you the benefit of the doubt, the dentists that we keep referencing, talking to them, even they were like, we don't expect you to know everything about dental injuries.
Yeah.
you are not going to see them that often. So that's what's the benefit of having a team dentist who you can always call and be like, hey, I don't remember exactly what it says on the position statement, but what am I supposed to do right now?
Yeah.
Send them a picture. Hey, they'll come see me like later today or like within the next 24 hours, stuff like that.
Also, the Academy of Sports Dentistry have a great little infographic to help
The little pink ones?
Yeah, the little pink ones. And there actually is a copy of that in the position statement.
Sweet.
So that's a good quick reference, right? They even said have that in your basically your dental medical kit as a quick reference. So if you're kind of like, oh, I'm not 100% sure, this is something quick to be like, okay, got it. I know where we're going. So I know what you're thinking. You're thinking action item, right?
I thought we did our action item, but I could do another one.
Action item part 2. Take pictures. That was my action item right there.
Great.
Remember, take pictures. Your team dentist will love pictures.
Yes. So if you guys are interested in getting the CUs for this episode, head down to the show notes. Thank you to Mass General Brigham again. We have a course evaluation and a course quiz that is you can take over and over again. As soon as you finish those, they will pop up with your certificate.
Yep.
And if you guys are new, we do every other episode as education or stories. But real quick, if you guys don't like listening to the fine print and you're going to click out of this episode, real quick, we are going on summer vacation. Yes. So we will be back in August like normal for season 4. I know that's crazy.
Holy smokes. Are you serious?
Yeah. Season 4.
Wow.
We're going to be back.
Good times.
So in the meantime, we're still going to be active on our Instagram at AT Corner Podcast. And now I'm going back to the fine print. So if you guys are new, every other episode we do is education or stories. This one was an education. Yep. We are coming back for season 4 for a story episode.
Yes. Which, by the way, we are super excited for season 4. We got some cool stuff we're cooking up. So
stay tuned.
Be ready.
Be ready. You got anything else, Randy?
Nope. Thank you for helping us showcase athletic training behind the tape. Bye.